Plus, thank you so much for taking some time to chat with us. We appreciate you willing to share your wisdom with us and our broader audience. We're just going to dive right in. First question. You've seen a lot of provider group M&A deals through your work. We're curious to know, like, what are the handful of metrics that you really hone in on to assess performance at a high level when you qualify these deals, especially given sort of this climate? How do you know that a group is performing really well?
Thanks. Glad to dig in on it. And I'll start with some higher level factors that I wouldn't even call metrics. I wouldn't start with the metrics. I start with some higher level criteria. And here they are in a couple of buckets. When we sit with the folks who are the leaders of that organization, we look for depth of the leadership, visionary at the top, execution in the middle, being able to, it's one thing to have an idea, but you can't get it done. It's another to have great execution with no direction about where you're going. There's a combination of those things that have to be there. And then we have to make sure that there's a command of the details. Sometimes we'll go in and say, not tell us, we won't say, here's the metrics. We'll ask them, what are the metrics? Because in some respects, we don't know. Sometimes we do, at least we think we do. But we really are testing to see if they have an understanding of their domain. So how do you, we're testing. How do you think about this little niche that you're in, or whatever it is? Might not be a small one, might be a large one. How do you think about it? That tells us some things. We're looking for domain knowledge. We're looking for an understanding of the macro drivers of the niche and the industry, and then also same time the connection to the micro about how do you execute, how do you scale, right? And there are different types of businesses. We'll bucket them. Some are really high growth, and some are low growth. And low growth does not necessarily mean a bad thing if it's got a good margin and sustainability and durability and protection against competition. We like some no and low growth business. I'm making a bid on one right now. They've grown as big as they can get geographically. They're as dominant as they can be. We'll still make a really good offer to them. And there's another kind of, you may have to bleep this out, but in the diligence area, we say to them that we really are testing, do people give a shit, right? There are some who do not, where they are in life and all of that. So we really do make sure that we've got people who are proud of what they're doing, understand the macro and the micro, can connect the dots, make sure it's scalable. If it's a growth component, have that fire in the belly, and give a shit about how it's gonna perform. So those are the things that we'll look for. And then there's another connection to it, which is once we've understood the metrics, we've asked them, we'll ask our own, but they'll give us their own metrics. We connect the dots on the P&L side and the side. The cash is, how much cash does it take to move it from point A to point B? And I'll tell you, we looked at one about a month ago, great P&L. And then we looked at the cash flows, and guess what? More than half of the earnings needed to go back into CapEx. It was a very capital intensive business, which helped us understand why the P&L was what it was. But we looked out 4 or 5 years, they were not generating cash, they were consuming cash, even though the P&L looked good. So you had at the end of the day, you had a great balance sheet, but that was about it. You had no cash. Great balance sheet meaning equipment and goods, things like that. So that's the way I think about it. Does that help? And you want to drill into anything on any of those aspects?
So many questions. And in many ways, it reminds me of actually some of my venture capital experience in early pre-seed stage deals, where you're kind of taking a look at the entrepreneur, right? And you're trying to drive at, does this person have the willpower? Do they have the passion? That sort of earmarker. I love it. Second question, right? And this is kind of around Medicare Advantage reimbursement trends, just sort of the general downsizing of it. It is no secret, right? There's a squeeze on that. But we always like to think that there are opportunities there still. So where would you think are those biggest pockets of opportunity that you can influence, like operationally? Like, in other words, are there any tactical tips that you have for navigating that squeeze?
Yeah. And it'll be a bit of a advertisement for the things that we're working on right now, because it's not an accident. It's not an accident that we are a company that we're in are doing what we're doing and where we're doing it. But in the managed care Medicare Advantage world, it's a huge population. You now have tens of millions of people. Half of the population of Medicare are now in Medicare Advantage.
Right.
And so where can you have it? It's very competitive, which is one of the reasons that you're seeing fighting over enrollment now for the first time. It used to be people were exceeding their expectations for growth. These last couple of quarters, they were not meeting their, even the United, the big, gold standard in the market, didn't meet their growth expectations. A lot of competition. So you got to be able to distinguish and differentiate. So figure out, what are you really good at? And it might be, in some cases, it's more and more, diabetes or COPD or dialysis, or is some there's a diagnostic aspect to it. There's a geographic aspect to it. You may have the best clinicians in a particular geography, in which case you can take the best care of people. So what's the niche? Understanding what are you good at? And there's still enormous spend in the Medicare Advantage area that are problems, and you have to figure out what those are. For us, the institutionalized seniors, which is a super small subset, still about 1.5 million people in the country in that category, the very frail, and then you start to think about what else can you focus on. So we'll look at the high proportion of those that have mental health issues, which is a very high proportion of senior citizens have depression. And I always say it's right that they should be depressed, in the sense that if you were in a nursing home and couldn't get out, and even if you were completely of right mind, you would be depressed, right? It's not, they're not good places to be. It takes a really good nursing home to be able to overcome that. And you try and overcome it with, again, back to your what's good in Medicare Advantage, with skills. So we'll do it with music therapy. We'll do it with companion benefits, things like that. You try and not do it with pharmacological solutions, although many people try that. So what's the niche that you're good at? What are you capable of managing of? What are you capable of managing? What can you deploy that's unique and different in that regard? So we go out there and try and find people who understand these niches, really focused on clinical, really focused on non-pharmaceutical if you can help it, really focused on non-invasive surgeries if you can help it. So there's a lot of folks who are out there doing procedures on peripheral vascular disease you don't need to do. So find the population where they are. The higher the risk, the more complexity for us, the better. Not everybody's good at everything. And then in the health plan world here, it's not, I've heard a CEO of a very large health plan say this: you can't just be good at 5 things, you got to be good at 100 things. There's that many things that have to be done. Diagnostic coding, enrollment and sales, managing utilization, managing providers who have to submit claims and then have calls about the questions about the claims. And then they have denials about certain claims and medical necessity reviews of other claims. Those are all things that have to happen in a health plan, and you got to contract with everybody at the right rates. Got to find the right providers. Keep the good ones on board. Get rid of the ones who are not good. And we find all the time with our data. And this is one of your third question. We'll get into that a little bit, but we look at behavior patterns. We look at how many visits are there, how many follow-up visits are there, how many hospitalizations associated with visits are there, what is the coding per visit, the CPT code has got complexity components to it. And we find patterns, and we find people who in a particular specialty should be seen, a patient's condition should be seen 60 days. They see them once a week. Why do they see them once a week? And, we'll talk to them about it. And we had one guy during COVID, he never should have said this. He said, well, I can't get people to come to my office because nobody's going to come to my office in COVID. So I got to go to the nursing home and I got to see all these people to make up for the amount of visits that I would have had in my office. And that's a lot of visits. He actually blatantly said he was creating revenue for himself by going to the nursing homes to see people. Well, we can detect that. And therefore you got to take those people out of the network because they're not doing members and CMS beneficiaries a favor. They're actually putting them in harm's way to a degree. We can paint a lot. If you had a session on that, we could paint us. We have a lot of stories to tell about people that are doing inappropriate things, and that's why value-based makes so much sense for the Medicare system, and to alleviate no value, low value, dangerous procedures that are affected to the beneficiaries.
I love that.
Let me pause there.
Yeah, just those couple of last lines are really powerful, especially because, especially given as we were going out and introducing the work that we're doing, I'm getting a lot of conversations around the sort of pros and cons of value-based care in and of itself, right? Around compliance and the alignment, right? So that hearing that is really affirming.
And I want to be sure I'm clear. That's a very small minority, right? But you got to
Oh yeah,
look for it.
absolutely.
You got to look for it. The vast majority of providers mean well, do the right thing, and they get to
Definitely.
the right outcomes and results. But there are some bad actors, and you got to find them.
Yeah, I think the latest sort of general trend reports were showing the sort of massive incentives, or not incentives, the massive benefits or outcomes that were actually on the health side for patients who are in value-based care worlds or environments. So we know it's working, and that's great. Let's dive into that last question here. Especially around sort of given longevity's characteristics. I'd say we would recognize longevity as one of these quote unquote payvider, right, type organizations.
We concur.
Yeah, yeah. And in that category, what we've seen pattern wise, that is often your role, the CFO role, has a lot of strong overlap responsibilities in general ops or operations, right? So to that end, what we'd like to know is how does longevity or you review its own operational performance of a business or of its business? Like, do you self-assess? Do you peer review? Do you get outside auditors? Like, what do you look for or do?
Yeah, we think we're a little too small still. We're still a bit of a baby organization to go out there and get a ton of peer review or outside audit. We do the regular classic audits for things like fraud and adequate controls and all that. But when you're talking about performance, we were lucky enough to be able to have excellent CEO and board leadership that's been able to bring in very good, experienced talent that is mostly here for the mission, not for the compensation. They have
Right.
most of our team has said, if I want to have an impact in the healthcare system, where can I have the biggest impact? Well, guess what? It's in the post-acute sector. It's in the skilled nursing sector. That's where the caliber and quality of care delivered is the poorest, right? So we think we can have the biggest impact there. So we're blessed with high caliber people who don't need to go outside. And now what they would like, and we're giving to them, and we get comments on this all the time, enormous transparency. We
Mhm.
give them, and we have people that worked at all the other health plans, and we say, I never saw this data. So how do you manage it? You tell people what's going on. First, you measure it and you report it. You tell people, like, here's what's going on. Here's what's going on in your everything from enrollment, right? So there's 100 people eligible in a building. Only 40 people are signed up for our plan. Why? So we'll ask that. So if there's a disenrollment, we'll ask why is there a disenrollment? So we'll dig in. Did they find out that there's a lot of reasons why there could be legitimate disenrollment, like an 85-year-old woman, her son moved to California. Well, guess what? She doesn't want to be alone. She'll go with them to California and he'll put her in a nursing home in there. We have that happen from time to time. So
Gotcha.
the issues are why the disenrollment. We ask those and we figure it out. Then we do some things based on that. We want to make sure that we've got exactly the right diagnostic coding, not too much and not too little, right? It's got to be accurate, got to be supportable. We know we'll be audited. And we tell people, here's why. I mean, we had this recent situation where, the combinations of COPD, CHF, ESRD all existed in a member. And some people said, well, I'm just going to code the highest one as opposed to all the other conditions
Right.
because they're important. And by the way, if you don't code the other conditions, you may not treat the other conditions, which may be dangerous. And then in the resource allocation world, there's an interactivity in the way CMS in their it's truly wisdom contemplated it. So it's not 1 and 1 is 2. It is truly 1 and 1 is 3 because there's a geometric component of the hierarchical components of that. You've got to get the right coding. It takes a lot of training, takes a lot of technology to track what was there that isn't there now. And if you have this and you have this, then you darn well ought to have that. And if you don't have that, what's missing? So there's it's a very detailed, granular view that drills down into all those criteria, the conditions, the claims, and the medications, and then lab results and things like that all tell you things. So it's a very detailed view on all of that. Then we show people all the other criteria that are affecting the quality of life of members. Believe it or not, it's not a good thing for a senior citizen to end up in a hospital. And some people, it's not intuitive in many cases. They say, well, if they need to go to the hospital, they should go to the hospital. They don't think about the fact that, well, hospitals are places where you acquire a lot of infections. They also don't think about the fact that if you're 85 years old, you may be somewhat, confused, right? And there's a component of dementia that's pretty high, 70%. Do you think a somewhat compromised intellectually compromised person should end up in a brand new bed with brand new people all day, every day, or are they better off in the place that they normally wake up and have the routine of food at this hour, et cetera? Hospitals are not good places. If we find that people are ending up in a hospital for no good reason, if there's legitimate reasons and they have to go, we're supportive of that. But if they're not going for the right reasons, you're actually doing harm to them and their life and their family. Think about it. You know, you have to call a daughter who's calling Fliss maybe 50 years old to say, Mom, who's 80, 85 years old, had to go to the hospital at 2 a.m. last night. And you know, think about the worry on the daughter and the family, the mayhem and that's caused there. So you want to make sure you're doing everything you can to treat the people in the place that they're most comfortable and you have the most capability. And again, if you can manage to keep people out of the hospital and avoid infections and having to get in an ambulance or having to get in a car and come back, you're doing a lot of good for them and their families. So that's a key part of it. So we measure. Did they go to ER? Did they get what they call either admitted or they get turned around and come back as soon as they could come back safely to the facility? That's key.
Right.
We track all that. How many happened? Where did it happen? What time did it happen? Did it happen on an evening? Did it happen on a weekend? All those things. Track it, systems, process,
Again, right, that
report
kind of
it,
thing.
show the transparency. And then we look at the same thing of, as I was describing before, a lot of the outpatient treatments, are they getting done in the right ratios, the right ways? And then I mentioned about follow-ups. So you may have had a follow-up to a minor surgery. Let's just say a cancer surgery to remove something from a dermatology procedure. They had Mohs is a type of surgery. There are a lot of surgeries that can happen that are appropriate and necessary. The question is, if somebody's being seen 2 years afterwards because the surgeon wants to continue to see them,
Right.
but there's no good need, then you have to have that data to be able to track it. And you go back to them. Is this medically necessary? Is this good for the member? Do they need to get in a car and get out of the nursing home and, get in and they might be in a wheelchair. And so let me pause there by saying there's about a dozen to 24 really key factors that we look at every single month, and we tell the nursing home and we tell the clinical team and we tell the operators, this is what you're seeing. And I listed a bunch of them out. Their enrollments and their disenrollments and their diagnostic coding and their inpatient admissions and their numbers of outpatient procedures and just follow-ups. We did give all that out there. Huge transparency. And lo and behold, it doesn't happen immediately, but a year in, the people who are in the field taking care of these beneficiaries, CMS beneficiaries, their patients, they get it and they operate. They have a good sense about what makes not only the business run, are they efficient?
Right.
Exactly. And they like it because they like the fact that they're now responsible for all care. They're smart enough to know if you take good care of these members, you are going to have better outcomes, and it's going to be higher satisfaction, higher enrollment, higher margins, everything. So that interconnectivity, and this is the beauty of healthcare, by the way. The better your quality, the lower your cost. I don't think there's very many industries that are like that. So our people understand that and they look for this data. So that's a lot of babbling, but these are the points that I would think are relevant to the topic.
That was fantastic. There's so many nuggets of wisdom and they're so great. We're going to mine that for a lot. So thank you so much.